So just a really quick thing, if you're starting a program to do medicine in shelters, make sure you know your state laws. In Texas, it's all very ambiguous and difficult right now, but it's important to at least know what the law says about what shelters can do to their own animals in the shelter setting. And about like our state has rules about you can't treat owned animals unless it's an emergency or it's spay and neuter or the owner is indigent. So those kind of things you have to know so you don't accidentally get yourself in big trouble with the law. There's a great book out there that has a lot of the basics of shelter medicine. So I think that's, if you're going to get any book, that's the book to get. And just a quick note on rabies testing. We often forget that rabies is a real disease, especially in cats. And if a person gets bit by a rabid cat and you don't know and you don't get the prophylaxis, you will die, 100%. So it's worth preventing that by doing rabies testing if there's ever a cat that bites somebody. Okay, Jordana is our clinic manager at APA, and she's going to cover some of this too.
Hi, I'm your kind of non-licensed medical person to go to, so I'm the clinic manager. And so we do an intake on every cat, every dog and cat that comes into the shelter. The basics are going to be FERCP, flea control, Strongid, we want to deworm everybody, microchip, rabies, and a combo test on everybody. This is the basic that every cat should get coming into the shelter. We do it on day 1. We don't like to wait unless the cat is going to be really fractious, is very unhappy. In that case, we will isolate it and put it somewhere overnight until we can safely handle it. We do some sedation if absolutely necessary on our barn cats, but for the most part, every cat will do this. We might wait overnight. If you do that, definitely put them in an isolation ward until they can get those vaccines on board. The FERCP is going to be important, and obviously the combo test. We want to know if everybody's leukemia negative or positive, and same with FIV. Wellness schedule. So we vaccinate every 2 weeks, between 4 weeks and 4 months on younger kittens. So what that means is, as soon as they come into the shelter, if they haven't been vaccinated previously from the shelter that we got them from, they'll get one on intake, and then every 2 weeks from that point until they're 4 months age, 4 months old. So that's pretty frequent. Some cats will end up with 6, 8 vaccines. That's okay. We don't worry about it. They're exposed to a lot of different viruses, illnesses, and so we want to give them the best protection possible. Adults, if they're 4 months when we get them, they will get a total of 2 vaccines. So they'll get 1, and then we'll booster, and then it's an annual vaccine at that point. We do deworm every 14 to 30 days. This is something that we especially kittens, you know, every time they come in for a vaccine, they get dewormed, just kind of like clockwork. And then flea control every 30 days as well. In severe cases, we might do every 2 weeks. If we're taking a kitten that has tons of fleas on it, we want to make sure that we get that under control, so we might have them back in 2 weeks. You don't want to let those little kittens become anemic because of the fleas.
And to that point, we try to set a protocol for everything. One of the keys for dealing with a large volume of animals is every animal of that type gets the exact same treatment. So if your protocol is that you vaccinate and do your whole workup at intake, then you try to do that 100% of the time. Because the minute you deviate from that and you do this cat maybe tomorrow and this cat next week, then you're going to forget about those cats and they're not going to get back into the main, the flow of everybody else. So that's probably the biggest tip we have for you is try to protocol everything and then stick to it 100% of the time. So one of the things that struck me when we first started is that our city shelter, the medical treatment that was being provided to them was good. It wasn't bad treatment, but the idea, their goal was different than our goal. Our goal is to get them into 100% of these animals into homes long term. Their goal was to get them to live through the 3 days that they're astray, and then for the ones that are highly adoptable and definitely going to make it out, then they would put a little bit more effort into those. But the ones that probably weren't going to make it out, they didn't get the same care. So what ended up happening when we had the big disease outbreak in 2010 is that only 50% of the animals were getting vaccinated on intake, and the other 50% had never lived before, so nobody would have ever known that they were incubating diseases. But now when we started pulling them out and they were living, the ramifications of not doing that intake vaccine were huge. You know, tens of thousands of dollars for us as an organization just starting out was almost something to put our organization in the ground. So it's a big deal. And so generally, in traditional thinking, they're treated to live through the 3 days, or if they're obviously injured or really ill, then they might be put down immediately. But those are the two choices an animal has on intake if it's a stray. So it's different because the goal is to save them all, no matter what the problem is, unless they're suffering so badly that euthanasia really is the kind option for them. And what I mean by that is if it was your own pet and it was at the end of its life, then you would pay to put it down somewhere. Those are the same kind of decisions we're using to euthanize. So euthanize and kill are two different things in our book. And so we say the word kill, it's not meant to offend, it's meant to distinguish between the two types of death. Animals die in a no-kill city and they're euthanized, and that's appropriate if they really are at the end of their life and don't have hope, if they have cancer, and you know, it is appropriate to euthanize. So this is what I said about the vaccine, systemizing the treatments. If you can write down, and especially if you have a lot of volunteers, a lot of staff coming in and out, relief veterinarians, maybe the vet, you have a different vet every week and they only come for a couple hours each time. If you don't have everything written down, then it's just going to be chaos because everybody's going to do something different, and then the next day nobody knows what was different from the previous day, and you spend so much time chasing your tail trying to figure out what's what. If everybody knows that the treatment is this for this type of problem, then you don't have to spend any time wondering or worrying. You just know, okay, well, nothing's written down. They must have started it on doxycycline, so today we're going to continue the doxycycline. You know, if everybody has that ingrained knowledge, then things are a lot easier. And then getting them out fast. One of the other things that I think is human nature is to hoard the animals in the clinic or in the shelter to do all the treatment yourself, but really you need them to leave. The very best thing for any animal, no matter how sick it is to get out of the shelter immediately. So using foster homes and adopters, get them out, let them be available to the public. There's no reason why an animal with a broken leg needs to sit in your clinic for 2 weeks letting the bone set. They need to leave. So that's the difference. And we just talked about this, euthanasia versus kill. It is different. The definitions in the dictionary are different. We have, as an industry, we've bastardized the definition of euthanasia, and so now it just applies to any animal losing its life in a shelter, and that's not true. And I think it helps, again, it's not meant to offend, but I think it helps to really put it in perspective if you consciously try to use the words correctly. The definition of kill is taking a life that is not suffering from an incurable, painful, or deadly condition. So some of the ways that we're different is that in a no-kill city, you generally have 2 options for herd health, actually in any shelter, well 3 if you consider death one of them. But if you're treating a problem, the one approach, and I think the traditional approach, is to, that's our approach, is to spread funds over all the animals by incrementally giving the most basic care until all are saved. So, and the other side of the spectrum is to save some animals with high dollar procedures, but then you don't have enough to save everybody. And so it's a real moral quandary, because there's some people who believe if you can't do it right, you shouldn't do it. But on the other hand, you know, where we're coming from is life is messy, and 30 years ago there weren't plates for bones in dogs and cats, and animals survived with broken bones. So you don't have to go to the most expensive option, even though that would be nice. But if you have only a certain amount of budget to work with, when animals are losing their life because you don't have resources, it doesn't make sense to put thousands of dollars into one when you could spend that thousands over everybody, and everybody ends up with being alive. And our goals, things that we'll talk about that in the fractures, but we want them to have a good quality of life too, so we're not going to make cheap decisions and have a bad quality of life. But when you can weigh fracture versus a cast or a splint versus a plate, the splint is like pennies, and that's going to be thousands of dollars. So it's important to know that you don't have to go to the extreme on every animal. You can, but.
And just one thing to add to that, it's okay from a non-vet, it's okay to ask your vet, what's the other option? Because a lot of times you'll only get the expensive option. This is what we can do. It's okay to say, well, what else can we do? What's the other choice? Because there usually is always another choice. So ask them.
If you have a vet in-house that's already part of as an employee, then hopefully that conversation would have occurred before they took the job. But if you have a vet clinic that you take animals to, they're used to working with clients. And the client is the one who makes the financial decision, the veterinarian doesn't. So the veterinarian's job is to offer the options. And of course they want the one that's going to be the best for the animal, which is always going to be the most expensive option. And, but you as the client have the right to say, well, I'm not going to choose euthanasia. I can't do this. What's the middle of the road? Triage, we call it scarce resource management because it really is, we really don't have a lot of resources. We don't have tons of money. We don't even have in-house blood work machines. We just got X-ray. We don't have a lot of resources. And so what that means is that we have to be very flexible with our drug choices. If our, as a veterinarian, I can say, I'd like this certain drug for this certain problem, but sometimes you just don't get that. And if you have all these other drugs donated, find something in there that might work because that's free and this is going to cost a lot to go through a pharmacy. Following protocols decreases your chaos and wasted manpower and wasted supplies. If one veterinarian starts one drug and then the next day the next veterinarian's like, oh, I don't like that drug, let's start this drug. It's just a huge churn on your resources. And then we treat everybody, with our protocols, we treat everybody the same. So if they have diarrhea, they all get the same treatment. If somebody doesn't respond to that first treatment, then it gets elevated to the next level of interest by the veterinary team. So that decreases the pull on the personnel, medical personnel, because the vast majority of shelter animals, like let's say for kennel cough, the vast majority of dogs for kennel cough are going to respond to a certain medication, and then there may be a few that don't, and those few that don't, that are still sick after 10 days, or they get very sick during the 10 days, then we know that's maybe not kennel cough, and we need to look a little bit closer and see if that's heartworms or distemper or heart failure. But if you treat everybody with a broad brush first, 90% of them are going to respond to your first attempt, and then you're only spending your time on that 10% that don't, which saves you time and money. Do you want to cover these?
So we treat what we see. We don't try to guess what we're not seeing. We don't try to speculate about what an animal may have, could have. Treat what you see. No expensive tests unless it's really critical to the treatment. So a lot of vets want to do a full blood panel on every animal. Well, that's not really necessarily going to help us as much as we think it is in some cases. So don't do it if you don't have to. If you're seeing a cat that has a sniffly nose, treat the sniffly nose. Don't need to do anything else yet. Because then what happens if everything's normal? A lot of times these tests are going to come back normal, and you're going to have spent the money, waited on treatment, and then now you're 5 days down the road maybe, and have lost that time. So that's what we do 100% of the time with our pets. We treat what we see, even if it's possibly something's going on. 90% of the time, if you treat what you see, you're going to get a result. Nature is your biggest ally. Animals have been around for a really long time and have healed themselves in many ways without our intervention. Not to say that we don't want to intervene when we need to, but they're pretty amazing animals. They'll get over a lot on their own without us constantly intervening. We use what we have. We don't order expensive drugs. It kind of goes back to drug choice. The vets definitely want their #1 go-to antibiotic, whatever it may be. But if you don't have to have it, you don't need it. There's a lot of cheaper options. Donations, we rely a ton on donations. Probably half of what we have right now in our clinic is donated. And so our vets will always go to that first before we think about ordering something. We'll always check our donation bin. And even if you get one tablet donated once a week of something, you can collect those tablets and pretty soon you have a couple prescriptions of it. There's almost always a cheaper alternative. So go with your donations and use what you got.
So some of the donations that we actually ask for, we put it on our wish list, is used medications, expired medications, and people bring them in, and I mean, it's unbelievable what people leave on our doorstep. When a pet dies or they rehome a pet, they're left with all the supplies that were left over. We get a ton of heartworm prevention for dogs. We get a ton of flea control for cats. Mm-hmm. We get lots and lots and lots of donations that way.
A lot of pain medications we get that way. Mm-hmm. So tangible supplies, syringes. We get a lot of insulin syringes, a lot of gauze, stuff that you use daily. Fosters and adopters will often want to donate, especially fosters. You know, they have their pet, they want to offer to chip in for it. Awesome, take it. Accept all donations. We don't we do ask for some specific donations, but we don't turn anything away. So if someone wants to come and bring us a box of stuff that looks like it's medicines and different things, we will go through it. And it takes some time, but it's definitely worth it. So don't turn away any donations. Volunteer help. You definitely don't want to turn away volunteers. They're going to be your biggest helpers. One, because they really want to be there and they want to help, and they'll do just about anything you ask them to, and they're always open to learning. Medicines, eye medicines, and flea medicines are what we do this most on, but break up tubes and bottles. It's pretty rare unless an animal is going to be on an eye medication or something for a really long time. Break up that bottle. If it only needs 7 days of an eye ointment, put it in a syringe. Send them with half of the bottle, something like that, so you can get multiple uses. Instead, that bottle, you know, half of it will get thrown away in 5 days. Alternatives to expensive meds, it's something to talk to the vet about. You know, again, it just comes back to asking them, what else can we use? You know, this one's really expensive. Is there anything else we can use on this? And foster homes. Save tons of money on foster homes, obviously, because they feed the animals, they provide litter boxes, toys, they'll pay for some of the medications. They're taking on a big bulk of the cost for us.
So some of the things we don't skimp on pain medicine. If an animal's in pain, that is not optional. In fact, by law, it could be considered cruelty if you don't treat an animal for pain. So there's many reasons why you should. But pain medicine is, there are cheap options out there, like gabapentin is not controlled. Tramadol is now controlled, so you can't use that anymore without the veterinarian writing the prescription. But gabapentin's a pretty good pain reliever, and it's something that you can purchase through a distributor like MWI. We clean up wounds, try to get wounds under control, because if you wait 3 or 4 days to see what happens with that, it's going to turn into a big nasty abscess and be much harder to take care of. Proactive treatment on things that probably will get worse. Eyes is one of them. Anorexic cats, which we'll talk about with fat cat anorexia. But if you have a cat that's not eating, it's an emergency. You need to have a way to monitor that cat every day. If it's in an enclosure and you don't think it's eating or it's losing weight, pull it out of a group enclosure, put it into a cage by itself so you can determine how much it's eating, or you can weigh it every day and see if there's weight loss. But a cat that doesn't eat for 3 to 4 days is going to go into liver failure. So they have a self-destruct button, and they will use it if you don't monitor them closely. And that happens a lot with the house cats that are turned in. They're completely stressed out by being in a shelter, and they'll just go on a hunger strike. Eyes can get bad very quickly if you don't treat them appropriately, and then baby illnesses. If you have a neonatal kitten that is not doing well, you can't afford to wait to see how it's going to be in 12 hours. If you have a kitten that has diarrhea and you started on oral medications, if it's not eating and it has diarrhea, we don't even mess around with oral medications. We go straight to sub-Q, because so many of them will die by the time you have a chance to recheck them, because they're just too little. They can't stand much. So these are just some of the things that we're going to try to cover quickly. But these are all the reasons why cats might be dying in the shelter. Injuries, hit by car. One thing to think about with hit by cars and any kind of injury is if the cat made it to your shelter, then it's already gotten through the worst part of the accident. So if you have the ability to try to treat it, I encourage you to, because once it gets to the shelter, if it didn't get killed by the car or whatever it was, then we like to think of it as it's trying to live, and so we want to help it live. And for the most part, we've been very pleasantly surprised with the outcomes of animals that are injured that come into our shelter, that you look at them and like, oh my God, what, that's horrific. But then they respond and they do better. Generally, they're coming in pretty quickly after whatever accident. We're going to start pain medicine and treat obvious issues like big open wounds, hydrating them, and then just wait and reevaluate. Some of the things that we'll see that we haven't found completely reliable in the shelter setting is head trauma. Obviously, if an animal just got hit on the head by a car, it's not going to be normal at all. But that doesn't mean, if you know that it was the car that caused this abnormal mentation, then give it time for brain swelling to go down and see what's going to be the end result. If the animal's out of pain and you can control the pain, then there's no reason why not to just give it a chance and see what it looks like after it's had a little bit of time. Blindness we see a lot with injuries, and it often goes away. Biting due to pain, a lot of times they'll be labeled aggressive, but obviously if they're in pain, they're going to be pretty unhappy about every situation. So the only problem with these other ones, like incontinence and paralysis, is that if you're wrong and the animal doesn't get better, then you're stuck with a pretty big problem that you have to have a way to deal with that. Either be ready to euthanize if the animal's not going to be continent after 5 days, or you have a way for them to get through your system and find a home, which is pretty hard with incontinent cats, but it's possible. So supportive care for trauma, we're going to watch them for 24 hours. We put them in a cage with comfy bed and pain meds, or in a foster home. You can support broken bones with even something like bubble wrap to help prevent the fracture from just flopping around while you're waiting to see what they do. A splint, we'll try to apply a splint pretty quickly. If there's a lot of trauma, we don't want to rush them to anesthesia or surgery, because there's so much that has just happened in their body, and they're more likely to die under anesthesia if you put them from one bad situation and then into the stress of anesthesia. So a lot of times we're going to give them time anyway before we go straight to a procedure. Tramadol is controlled, just mentioned that. Gabapentin is the one I mentioned that is not controlled, which means you don't have to keep the log, and you don't have to have a vet on site to use it for the gabapentin. The other things we use is NSAIDs. That's like your Metacam. And the only problem with Metacam, I would not, it's so easy to use because it kills pain, and it's a liquid oral. But the problem is if you give it to a cat that's not hydrated or is not eating, it will kill them because the kidneys will suffer from it. So I would use something like gabapentin much more frequently and with little regard to that. But Metacam can be very dangerous if the animal's not feeling good. Prednisone's another one that we don't use very much at all because it decreases their immune system, and so if they're in the shelter and they're exposed to viruses, then they're going to be more likely to pick up those viruses. Okay, so bone fractures, surgery or no surgery. We splint almost everything or do immobilization. The immobilization, the whole purpose of fracture repair, like the underlying theory of fracture repair, is that you want to keep the fracture, you want to give it enough time for the fracture to bridge whatever gap is in there and heal. So the main way we do that is immobilization, by not moving the fracture. Every time the fracture moves back and forth, it's breaking the bond. So immobilization can occur in a cage with very little movement, with no splint and no surgery. That is an appropriate form of immobilization. Splints are better because they're going to have more protection if the animal gets up and starts moving around. Surgery obviously is way better because that is permanent fixing of the bone fragments together. But really the whole point of fracture repair is just to keep it so that it has long enough to attach back together to itself. In a kitten, that could be a week. I mean, they heal so fast. Same with puppies. In an adult, it's going to take a little bit longer. We will amputate if there's open wounds where the bone has popped through. Amputation's a lot cheaper than bone fracture repair, and so that tends to be our second choice if we can't get it to heal on its own. And we will amputate animals. We see a lot of, not a lot, but some cats that come in that got hung in a fence, like they're climbing a fence and they get hung under their armpit and their front leg is dragging. I don't know if you've seen those where they just can't get their leg to right and start using it again. We've seen a ton of those resolve with time, like a month, and they'll just get better on their own. We will go to amputation if during that time they start to mutilate the front of their paw. So if they mutilate the front of their paw from dragging, then we have to take the leg off. It's really hard to prevent that or fix that once that's happened. But if they're not, then give them time. You'll be shocked at how many will actually start using the leg again. And we don't use amputation for fractures that are not open. So that's one thing that I've seen a lot of shelters do is just amputate a broken leg. I would always recommend just giving the animal time before you go to the amputation route, because if they can have one leg that is slightly less useful than the other three, that will help them later in life if they get arthritis in the other limb. There's all sorts of reasons why you might want one leg that is just not quite as good as the others, but is still functional.
And these are cases that, while they're going through the supportive care, they can be in a foster home. I feel like our tendency is to want to keep them in the hospital. That's probably one of the worst places they can be in a lot of cases because they're stressed, they're exposed to illnesses. So put them in foster homes while you're doing all this. Mm-hmm. Just make sure there's communication. Yeah,
you can't send a cat to a foster home with a leg that's broken and no explanation on what they're looking for, what the next steps are, how long is this going to take, how do we know we need to go to the next step of amputation or some other type of repair. We do bone surgery if a joint is affected, and the bigger animals have priority of money that's used on bone fixation. So a big dog with a hip that is broken is going to be more likely for us to spend money on than a cat, because a cat has a more equal weight distribution, and same with a Chihuahua, than a giant dog. They have a lot of weight on that one leg, more like a horse, and so they can't, they're going to be in a lot more pain over time. And then bone surgery, we'll go to bone surgery if the fracture doesn't heal, or if there's more than one leg. And this dog was in San Antonio. I don't have a good one of a cat, but this dog had two legs that were broken, and she healed them herself out in the world and ended up at the shelter. The fractures were healed, and she was on the euthanasia list for her fractures, but she'd already survived. She'd already immobilized herself and fixed her fractures herself. They were just kind of janky looking, but she's alive. She was happy. We got her adopted out. But anyway, it's just, again, it goes back to the point that animals can do a whole heck of a lot without us trying to micromanage every piece of it. That was her other leg that was broken. It's just crazy. So she probably healed in a ditch somewhere. I mean, I don't even know how she did that on her own with two broken legs. Okay, so benefits are that we save more lives because we save more money, and so we can spread it across more animals. It costs less, decreases the amount of time we spend going in and out of surgery at different clinics. The risks is that you might get a weird bone healing, and as long as the animal can bear weight and can do okay, that doesn't matter. They don't need to look perfect in the mirror. And it takes longer to heal, so surgery is going to heal in a week or two. If you use immobilization or a splint, it might take 6 weeks, 8 weeks, so it does take longer. They may not heal at all, very few, but that does happen. And then regular vets and adopters can be mad if you didn't do the full Taj Mahal treatment, so you have to be ready to educate people before they pick up the animal that this is why we chose this option. And most of the time, once you explain that we don't have the funds, it was either this or death. Surgery, $2,000 surgery was not in the cards for this animal, then most of them are okay with that decision. Honey Biscuit was a cat that came in. She was hit by a car. She looks horrible. We pled her from the euthanasia list, and she ended up going straight to a foster home. So the foster was willing to take her with her horrible, ugly eye. And the next cat that came in with the same injury, the foster wrote this on our little blog about trying to get somebody to take the next cat. I don't know if you can read that, but she said, I would take this little boy in a heartbeat. It was such a rewarding experience to see Biscuit mend and find a great home. But she can't take him because she has another one. So the good thing about using fosters is they help increase your network of ability to save animals, and they help, you know, they can be your go-to people for these types of really hard ones. That was her after her surgery, so we did get her eye removed, and it cost about $350, and all of the money was raised immediately. Eyeballs, people freak out about eyeballs, so if you have a picture like that, post it on Facebook and ask for donations, and you'll get the entire surgery covered in an hour. Seriously. Biggie was shot and had a fractured back leg, and the wounds had healed, so this one probably should have been amputated from the beginning because there was an open wound going into the bone from the bullet. But we decided to try to bandage it for 2 months, and it never healed, so we ended up doing the amputation, and the cost was about $400. So, like I said, if the pet is still fighting, we are going to fight for it. And eating equals will to live. In cats, that's a little harder than in dogs, but if you've got a cat that's eating and it looks like Honey Biscuit, that was one of the things Honey Biscuit was doing with that horrible eye and broken side of her face. She was still eating. It's like, how can you turn that down? You know, we didn't want to walk away from her because she was obviously trying. And sometimes with trauma or illness, they might not eat right away, but if they're not extremely emaciated or have been going through this for a long time, it could be the stress of surgery, it could be the stress of the shelter, could also be, you know, the trauma, the pain. So some of the infections we see are ringworm, mange, we also see viral infections, and we treat all of these things, parasites. Ringworm, okay, there's a whole lecture on this, so we won't spend very much time on it, but this is probably the #1 disease killer of cats in shelters because it's so contagious in a shelter setting. And people are afraid to adopt these cats out because they're worried that they're going to get the people sick and all of that. Our team has come up with a lot of the waivers that you can just copy if you want to, that help for adopters to sign when they are adopting one of these cats, fosters. We use them even for people who walk into the ringworm ward. They have to sign something on the wall that says, I understand there's ringworm in here. And you know, we learned all that the hard way every single instance, but we still aren't going to go back to killing ringworm cats. So we're going to figure out a way to protect ourselves and just inform as many people as possible. And we get a ton of these guys adopted. We get them treated and adopted. One thing, and I won't spend a ton of time on this, we use terbinafine and lime sulfur dips. The black light, there's a lot of misconception about the black light. If the black light is not fluorescing the actual hair shaft, it's not a positive test. So I can't tell if this cat's actually positive. It could just be the skin, because all the dander will fluoresce. And so a lot of cats are called positive ringworm when their skin or their dander or food is fluorescing, and it's not positive unless you see the actual hair shaft fluorescing. So that's something really important to remember. We have a lot of strategies to deal with this. One that helps us a lot is the cattery clearance exam. So every cat that is in our system somewhere, before it can go up for adoption, it has to go through the clinic or one of our most experienced counselors to get a checkup to look. One of the things they're looking for is ringworm, so that we don't accidentally put the cat into an adoption place, especially a group habitat, and then spread ringworm all over the world.
And two of the things that you want to make sure if you're saving ringworm cats, you want to be able to identify it really well. You need to just train your staff, train yourselves to be able to identify it. And second of all is cleaning protocols. You have to have pretty strict cleaning protocols so you're not spreading it to non-ringworm cats. So those are two things that we, on a daily basis, work on, is identifying it and then cleaning to contain it.
We do, in the wintertime, we get all these cats adopted. So summer, they're competing with all the non-ringworm cats. They don't really get adopted until they're cleared of ringworm and then go up for adoption. But in the winter, that's generally where we have kittens, because the other shelters don't want them with ringworm, even if they're kittens and they don't have other cats. So it may be the only place in our whole facility that has kittens, and so they get adopted even with ringworm. So that's what I mean is keep them open to adoption at all times. In our ward, we have one staff person, and then that staff person has been able to develop a fungus fighters volunteer group, and they come in and do dips twice a week, and they clean everything, all the bedding, they bleach all the floors, the walls, everything. They do that twice a week to help decrease the contagion and get these guys out faster. So that's a before and after. I'm sure everybody's seen those before. They're very rewarding. So ringworm caught in the shelter, that's a very hard one. And as we talk about the next group of contagious diseases, there's so many ways you can spread ringworm or any contagious disease in a shelter. It's like kindergarten. It's the nature of having too many animals in one building, just like too many kids in one building. They're gonna spread stuff. So you have to take as much proaction as you can to prevent that. It can take days to weeks to show up. Your staff needs to be educated. Always looking for it on intake. So our staff has to look for ringworm on intake. It's not just do the shots and off you go. They need to be trying to identify ringworm so that we can put them in the ward at the right time rather than wait 5 days for it to be really obvious and then move them to the ringworm ward because they've already spread it in the cat area, and then before adoption. If you have a ton of ringworm, one thing you can do is lime dip everybody twice a week, all your adoptable cats. That's one way to help decrease the burden of spores in your environment and in your cats, is just proactively treat everybody. It's not that expensive, but it's very labor intensive. We save FIV positive cats. We consider them regular cats. I wish there wasn't even a test for this because it really has no bearing on their longevity and what quality of life they have. The vet I used to work for said that cats die with FIV, they don't die of FIV, so it's just a lifelong label that they've got. We actually put them in our, we mix them with our cats. We really don't care about FIV. So that's kind of a non-issue. Cat URI, that's a huge issue. Vaccines will prevent the most severe cases. When our city was not vaccinating for cats, for URI, and they were, and even before that, they weren't vaccinating on intake. The reason they went to no vaccines was because they were afraid that their vaccinator was giving each cat by accident the virus. But really the problem was they weren't vaccinating the minute the cat entered the shelter. So they knew there was a problem, but they didn't know what the real reason was. The minute that they did 100% cat vaccines on intake, we don't see that anymore at all coming out of the city. When we first started, that was all we got, was cats that look like that. So it makes a huge difference. If they do get really bad URI or even mild URI, nebulizing is a great thing to do while they're in the shelter or in foster home. Force feeding if you have to, if they're not eating. Again, anorexia is a huge problem for cats. We start them on amoxicillin or doxycycline is our protocol. And if they're severe, like not eating, we will move to a bigger drug, Zithromax or Baytril. There's all these eye meds. We use gentamicin mixed with sterile water as a really cheap way to make eye drops. It stings for like 1 second when put it in the eye, but when we were going through all this, we found that as a home remedy because we couldn't afford all the eye drop. One tube is like $10, so we couldn't afford one for each cat. And then foster homes, try to get them out of your shelter to an isolated area or to a foster home.
And you can teach your fosters to force feed. I think force feeding can be intimidating, but it's easy to do. Anybody can do it. Your fosters can do it. So have them do it.
Mm-hmm. Yep. Fat cat anorexia. If you get a cat in your shelter that looks like that, it's probably going to go on a hunger strike, and it's probably going to get liver failure and die if you aren't watching very closely. These cats are just not made for shelter life at all. So if you see that shape come in, watch it very closely. So they are that big because they've lived in somebody's home and been overfed and pampered their whole life, and now all of a sudden they're in a shelter, and the shock of going to a shelter is overwhelming. They really do want to commit suicide, I think. But if you can get them into a foster home, if you can watch them closely, if they do have to stay in your shelter, minimize the stressors for them, like noise and a lot of visitors. Keep them in an individual cage rather than putting them in a group habitat so you can see exactly how much they're eating, or weigh them every day with the same scale so you can see if they're losing weight over a period of time. Offering different types of food. Sometimes we don't know what they were eating before they got there, so they may not like crunchy food, or they may not like canned food. So offering them different types of food might help them start eating. And if they go more than 24 hours, you need to double team getting them to eat, because if they keep going down that path, they're going to end up with the liver failure and all the things that need IV antibiotics and hospitalization and a feeding tube, and you know, that's just Pandora's box. Force feeding, you can do that in the clinic, but and that's one thing we use volunteers for in our clinic, is they can do all this stuff we don't have time for, like force feeding. And but it's really hard, and it's, when you're really busy, it's easy to forget about the 2-hour force feeding that needs to happen on this cat. And so at the end of the day, you're like, oh, you only got 1 force feeding in, and that's not enough. They're not going to survive even with just a little bit of food. They need to eat their full calorie amount to be able to live.
I was going to say, if they do, there's a minimum that they need to eat. We do have a force feeding chart available. If you guys don't know what that is, per weight, that we can get you also.
It might be in the manual, but if not, we can get it to you. And then sometimes they need sub-Qs. So diarrhea, panleukopenia is the one that's the worst, which we'll talk about in a minute, but often it's from stress or parasites or diet change in cats and kittens. That's where we use our protocol. So the first time we see diarrhea in a cat, we're going to treat them the same as every other cat that shows up with diarrhea. And then if they don't respond, then we're going to start thinking a little bit more critically about, well, why is this cat not responding to the standard treatment? And then we might use a different type of medicine or food change, who knows. And we control it. Penicillin G has turned out to be our savior for cats with diarrhea. We see so much kitten diarrhea, which the nursery will talk about if you're going to that class, but also the cats that come in that move from our main cattery to an adoption facility or foster to an adoption facility. Sometimes they'll break with diarrhea, and we used to do this whole big concoction of meds to treat them as our protocol. We started just doing penicillin proactively, prophylactically, like we do with our kittens. The minute the kittens come in the door, they get a shot of penicillin. We don't even know if they have diarrhea, but we know they will get diarrhea because they went from mom's milk to formula. So, and that cut down our diarrhea in kittens dramatically. We started doing that in all our cats, and when they make a move, we give them a shot of penicillin, and it's worked like crazy. It's amazing. So I'm sure there's no good medical study on why that is working so well, but there's probably some gut flora changes that occur when they're stressed or they switch foods, and the penicillin just kind of nips it in the bud. It's a one-shot deal too. But of course, if they're not responding or they're very young, we will deworm them, might try some diets. If they do have a contagious illness, cleanliness is important. Coccidia can be a real big problem in a shelter environment. So cleaning the litter boxes is super important, which sounds very elementary, but it can be hard when you've got a lot of cats. So ensuring hydration, making sure they're eating and not vomiting. With diarrhea is not a big deal, but if they're not eating, it's a big deal. So that's why you always want to look, like your first question when somebody brings to you, this cat's got diarrhea, is, well, is it eating? Yes, okay, well then we're going to do this slow protocol. If it's not eating, then that's kind of a bigger problem, and there's probably something more wrong with the cat. Parvo testing, use the Parvo test to check for panleukopenia. So if you've got a cat that's vomiting, a kitten especially, that's vomiting and having diarrhea, then Parvo testing them is not inappropriate. You have to be careful because everybody's going to want to test every kitten, and that's a really expensive undertaking. But selectively choosing kittens that just aren't fitting the regular diarrhea mold is probably not a bad idea, to make sure you don't have panleuk running through. Okay, so this is a little video. I don't think I can get there. Let me see. We see a ton of toxoplasmosis And this little kitten, so neurologically, when you see a cat tremoring or a kitten tremoring, this is really severe, but sometimes we'll see it when it's not that bad. We treat them for toxoplasmosis, and that's the treatment we use, clindamycin, because most of the time it's toxoplasmosis. I think our stray cat population has a lot more toxoplasmosis than we know, and clindamycin gets it out of their system and kills it when it's in their brain. It's a parasite that they can get that they get it from eating mice, and it's the one that pregnant people are terrified of with litter boxes. I think it's really common in cats. And so most of the neurologic cats that come in respond to clindamycin, and they're not neurologic in like a day.
And clindamycin's,
yeah.
And clindamycin's cheap, and you'll see results fast. So rather than go through testing, do a bunch of stuff,
right?
Start the clindamycin, and if it's going to work, it's going to work pretty quick, and you'll have some results.
Yeah, that's one of those that you want to ask the question. If you have a vet saying, well, we need to test for toxoplasmosis, then your question is, well, what are we going to do if it's negative? And their answer probably will be, we're going to treat it as if it's toxoplasmosis. So just treat it, and if it gets better, it's probably toxoplasmosis. The other rule out, though, is rabies. So that's kind of a big deal. So you want to make sure you don't get bit by this neurologic cat, and if you do, it needs to be rabies tested. And if you work at a city facility, you probably want to test anything that's neurologic that dies within 10 days of showing a neurologic sign, just to be safe, even if it didn't bite you. A lot of the nonprofits don't do that. But if you have a bite, you have to, no matter where you are. Okay, so some of the chronic diseases we see are feline leukemia, which we'll talk about in a minute. These are the ones that are hardest to deal with in a shelter because they don't have necessarily. This is another reason to get your cats into foster homes quickly, because then they have an opportunity to bond with a person. And one of the big obstacles for a cat with a chronic problem is that they don't have an advocate. You can have counselors that love them and they're part of your shelter population, but when they've got a really severe problem that needs to be managed, you really need somebody who wants to help them manage it, if that makes sense. So trying to get these cats into foster early is a good thing. Frustrating, all of these are very frustrating. Kidney failure, diabetes, hyperthyroid, incontinence, that is the last piece of no-kill in our book. It's the very hardest to find find somebody who wants to adopt. It's very hard to find a foster, and it's very hard to keep them from developing sores in the shelter, and heart disease. So our rule of thumb, I think I took out the slide related to this, but our rule of thumb for chronic diseases is we will save them. If they've got a good quality of life at the shelter that we're pulling from and they seem to be happy, we're going to pull them. If they look like they're already on death's door and they're coming in with a history of this, then we'll probably let them go. If they do get into our system, then we can't afford to do tons of heroics on them. So we're for especially kidney disease, it's not going to turn into an IV hospitalization stay and frequent repeated blood work. We're going to just do the basics, sub-Q fluids, maybe a course of antibiotics, see if it gets better. And that's appropriate. Lots of owners do that for their own cats if they can't afford to do the repeated hospitalizations and tons of diagnostics. Same, diabetes is a little different because you can't really, there are ways to control it with food, but often you have to go to insulin. But we try to choose the least expensive option that is not death, if that makes sense. Okay, feline leukemia positive cats. We have a little talk on this today, or this weekend, so I'm not sure that we're going to spend much time here. Number one takeaway is that the test is unreliable on whole blood. So lots of vets don't know that. I didn't know that. I've euthanized cats for being feline leukemia positive without doing a serum test. I didn't know until I got involved in all this and was reading the fine print, and guess what? It's only accurate on serum. And red blood cells will react with the test and cause a positive test falsely sometimes. So you get a positive cat, you have to take another sample, spin it down, and run it with just serum. And then you'll know, is it really positive or is it false positive? If it is positive, then we will retest in 4 weeks.
4 weeks. We'll retest every 4 weeks until they're 3 months of age, if they're young kittens. Once they're 3 months of age, if they're still testing positive, they're probably going to be positive. They're not going to convert back. But over that time period, over 3 months, we've had tons of kittens convert to negative, and they're negative kittens. You just got to give them some time.
Mm-hmm. And as we're understanding more about that disease, it seems to be related to how long they're with a positive mother. So some of these kittens that come into the shelter away from their mother, they might test positive, but then they're no longer with the positive mother, and maybe they're fighting it off. We don't know what's happening, but it happens much more in kittens than it does in cats. We started retesting because a lot of times we were getting the test that said FIV positive and FeLV negative, or vice versa, and it would be the exact opposite of what our test showed. So we just started retesting everybody. Are we still doing that?
Mm-hmm. Yeah, we retest. If we get a positive result from any shelter, we'll retest 100% of the time and verify results. And I would say probably maybe 15 to 20% of the time we have different results. So a lot of times, even if they say they've serum tested, we'll still get a negative test when we test. So we always go by whatever we do. We saw it. We know we did it correctly. So we tend to not rely on other tests out there that we get.
And this cat has actually been alive for many years with feline leukemia positive, but for the norm is 6 months to 2 years after diagnosis is how long that they can live healthily before getting sick.
Sorry, one more thing. And those kittens that seroconvert, so those are kittens you want to put into foster homes. You want them as healthy as possible during this time. You want them no surgery, no spay-neuter. You want to limit their stressors in life in general and give them the best chance, because it seems like the better immune system they have, the better off chances are that they're going to seroconvert.
We started a ward for them, and we didn't think that we'd be able to save them all, but in Austin at least, we're able to save all of the feline leukemia positive cats with our sanctuary, and they mostly get adopted. This feline leukemia is not a barrier for adoption for most adopters, for a lot of adopters, I should say. It's a barrier, we think it's a barrier, so we don't put them up for adoption, but when you start offering them for adoption, a lot of people actually will adopt them. They want to give a cat a chance. We offer the end-of-life care, so they don't have to spend thousands at a vet clinic later in life. And often that's euthanasia only. Like, these cats don't spend a long period of time sick and then die. They're healthy, and then bam, they're really sick, and then they die. And so it's not a huge expense either.
And what we have found also is that those same people will come back and keep adopting from you. So we'll see them once a year. They'll have a good experience with the cat they adopted. It got sick, we euthanized it. They'll come back and adopt another feline leukemia positive cat. So.
This one we do keep isolated from other cats, of course. And we do have a lot of students that don't know where they're going to be in 2 years, so they're okay with the 2-year commitment. So trying to set priorities, it's hard to even write it down. It's hard to know what your resources are, but most things are going to have a positive prognosis if it's an acute problem. So acute meaning they just got hit by the car, as opposed to they were hit 6 months ago and somebody's been caring for them and they're incontinent still because of it and paralyzed. That's very poor prognosis. If they just got hit by a car and they can't use their back legs, that actually has a pretty good chance of resolving because they're still healing and they need a little bit more time. Chronic problems are harder. But it depends on the problem. So it's just important to know what you're going to do with it if you're wrong. I wouldn't look at everything like that, but I think if there's a very big problem like incontinence, you just need to know, you need to have your plan in advance so that you don't have to fight about it later. If your plan is that we can't adopt out incontinent cats and we have to euthanize, then everybody needs to be on board with that before you start taking those cats in, because what will happen is that if a fight breaks out, then whoever's in charge of pulling just won't even try for any more in the future. And that damns a lot more animals on the front end than if you have a solution in place for, whatever the worst outcome is. Excessive drinking in a cat often is kidney or diabetes, so that's probably more chronic than an acute problem. Chronic weight loss in an older cat, incontinence. So those are things that are more difficult. Chronic diarrhea is really a 50-50. Sometimes the owner never even treated it at all, so it's really easy to turn around, and sometimes it's really bad, like years of diarrhea that is going to take years to keep going with you, no matter what you're doing to. So maybe just pull a couple of those at a time if you're trying to decide. So the way that we're able to get these animals treated is we use volunteers, we use fosters. We're constantly recruiting. Ashley's back there, who's our foster manager, constantly recruiting for more fosters and trying to upgrade our current fosters from regular foster to medical foster. And a lot of people want to do that. There's a great joy in helping an animal get over an illness or an injury. So let people be part of the solution. Educate your fosters and your volunteers on how to do sub-Q fluids. I know a lot of vet clinics that will show you one time how to do sub-Q fluids and send you on your way. There's no reason why we can't do that for fosters or volunteers. They don't have to be medical experts to do some of this at home. And nebulizing, something that anybody can do. Bandage changes sometimes can be done by anybody. Force feeding can be done by anybody. And just being the home base for the volunteers and fosters is important. Chip-ins we kind of glanced over earlier, but chip-ins are a great way to raise funds for your sick animals. Like I said, the one with the eye raised a lot of money really quickly, and we use a company called Razoo, razoo.org. .com. And you can put the photo of the animal and its story, and then you can link it to a blog or Facebook, and people can donate to it. And those are really successful. So if you don't have a ton of money, that is, and nobody does, that's the way to go. Because these are the most tangible issues that people want to donate to anyway. Nobody wants to donate to your general fund. They want to donate to the animal that needs it. If they can see the photo of the animal that needs it, they want to donate to that. So it's your job to put it out there.
I think one of the biggest things is it's really a kind of a community effort between your fosters, your staff, your volunteers. Everybody has to put in a little bit. So if you can communicate well, it's one thing that we have learned over the years is communication is hugely important. Your fosters have to know what to expect, what you can do, what you can't do. And same goes the other way. You know, we need to know what they can do, what they're comfortable with. We don't want to put a foster in a situation that we know they're not comfortable with because we're going to lose them. So just communication is very important.
Mm-hmm. I have a quick little video that I'll break up the monotony with a little bit. I love this video. Get out the way. It's going to be blurry.
Okay, come get it. Good girl.
Sorry, the quality's really bad, I guess, on the screen. Kitty had feline leukemia and FIV. So we might go, we're covering calicivirus and panleuk, but they're pretty much, the procedures are the same, so we might just go through that pretty quickly so we have time for questions. But let's see. This is a picture of our ISO room. It's a laundry room that we put in cages so that we can have a place to put cats that we're worried about, that don't look quite right, might have a simple illness that they can't be part of the cattery population, we can't find a foster. Having these little nooks and crannies to put animals in, as long as you can keep track of all the nooks and crannies, is very helpful for keeping your whole population healthy. The traditional way is to get the sick animal out and kill it. Our way is take it out, same principle, take it out, but put it somewhere where we can watch it and help it get over whatever it's got, and then can put it back into the whole population later.
People's offices are great places for these kinds of animals. So isolation, you have to know how it's spread. So if you're trying to combat a disease, we need to know how it's being spread. So we know, is this one Khaleesi specific?
No.
Okay, so aerosol saliva, fecal matter, fomites. One thing that I personally worry a lot about is fomites, which is us, it's pens, it's doorknobs, it's everything that we touched after touching that animal that we don't even think about. Because that's what's going to live in the environment and keep spreading the disease. So you need to know what kills it. A lot of things, you know, like coccidia, ammonia kills it. Nothing else really kills it. So you need to know what exactly kills it, how you're going to treat it, where you're going to put them, and how long do you need to keep them isolated. And then reintroducing them into the population, how does that happen? For example, pan-Luke, they're going to have poop on them. You need to get the poop off before you put them back into the general population. So Khaleesi virus, so we went through a virulent Khaleesi outbreak, which was pretty scary. Once our vets identified it, we kind of all looked at each other, deer in the headlights, and said, oh my gosh, what are we going to do? Because at that point, our whole cattery had been exposed, and we had several cats that had Khaleesi virus, this virulent Khaleesi virus. So what we did, so identifying it, so oral ulcers are really going to be the only way to identify this, because they're going to have upper respiratory symptoms, but the ulcers is what's going to differentiate it from anything else. So that's what that was our trigger. We had a lot of this going on, which was really nasty. And once it gets to this point, it's pretty obvious. You say, oh, well, I can see that. Well, it takes a while for it to get this bad. It starts off as a little tiny ulcer on their tongue.
Yeah, and one thing, this came out of the UC Davis materials, and the picture on the left is Khaleesi. The one in the middle is from licking bleach, and the one on the other end is herpes virus. So it doesn't if you have just one cat with ulcers, that doesn't mean you have Khaleesi, but it does mean you need to isolate that cat to see what's going to happen.
So do you want to talk about?
Sure. So the difference between virulent Khaleesi and regular Khaleesi, Khaleesi is preventable. The normal Khaleesi is preventable with vaccines. So vaccinating on intake, all those cats that we saw that were so sick coming out of the city probably had Khaleesi, but they had the regular form of Khaleesi. Virulent Khaleesi attacks animals that are well vaccinated. It tends to attack adult cats. And it is not a new kitten problem. Kittens aren't as affected as adults, actually, with the virulent Khaleesi. But kittens are more affected with regular Khaleesi than virulent, if that makes sense. So kittens aren't as affected. It mutates into different strains, so it's very hard to build up immunity to it, which is why the vaccine doesn't prevent it. And it looks like ulcers in the mouth, might see skin lesions. They've even reported limping. So if you see all of these signs together, and the worst thing we don't want to create mass panic because there's all sorts of horrible viruses out there, honestly. But as long as you know what to look for and how to prevent it from spreading to everybody, if you see something that's suspect, removing that animal from the population is a good idea. So you're wrong, put it back in two days. But it just helps to keep an animal isolated that you have any question about, and part of having the questions is knowing what to look for. So if you know oral ulcers are not normal, then you'll have a better grip on what to do next. It's spread through upper respiratory mostly. It can be spread through poop. It can be spread through pins. It's very hardy. It's like parvovirus in its hardiness. So most upper respiratory viruses are immediately dead as soon as they dry. This virus is like parvo. It stays on everything. So if it gets on your shoes, you're tracking it all over the place. It's on the buttons on your shirt or on your smock. It's there, and then another animal licks that spot. they can get it. Or your hands are dirty and you stick your hand in the mouth of a cat, then you've just spread it to that cat. So you, like Jordana said, you are more likely to be the spreader of this than the cat because it sticks to everything.
And we do have in our medical clinic, we actually have a no cuddling policy. So we don't want our staff or volunteers going and cuddling with every single animal that they see, because if on the off chance one of these cats is sick with something like this, we're not then spreading it to every other cat that same day. So we handle the animals, we treat them for whatever we need to, but we try to make a conscious effort not to rub them all over ourselves, rub them all over our faces, that sort of thing.
Yeah, we had a bad, that came from our receptionist was holding a puppy that was crying all day for the spay-neuter clinic, and she also brought in every other puppy, and then she also gave back every puppy to adopters and fosters. The puppy she held all day had parvo, and so we exposed like 25 other puppies to it, and so it just doesn't make sense. You don't know what you've got. You don't know what they've got, and so if you're holding them, we all want to, that's why we're here, but you just have to use caution. One of the vets that I used to work with said that you should just pretend like they're covered in poop and hold them like this, because if you're holding them like this, you can't clean this. You can't clean everything up here. You can't clean your necklace. You can't clean your hair before you touch the next animal. So it's important to keep that in mind. So it's killed by Clorox, just like parvo is. Creating an isolation unit is really important. If you have an outbreak of this where you have multiple cats, then you need to create a place that they can go where, and you have different stages to that. So if you create an ISO unit, it's just like our parvo ward, and if you have cat disease outbreak, going and listening to the parvo presentation is not a bad idea because it's the exact same principle. If you have a positive animal and its litter mates or its cage mates, they all go into isolation for treatment because they've been directly exposed. If they're in the same vicinity, then we're not going to call them exposed, but we want to watch them a little bit more carefully than the rest of the animals because they might have gotten a speck of it, squirted into their cage. And so you want to create an isolation area. The scrub in and scrub out. This is really important for making sure that your staff and your volunteers are not bringing stuff into the ward, bringing other diseases in, and you're not bringing that disease out. So if you have a viral disease, nobody should ever be in there without the appropriate clothing, shoes, gloves, whatever it is, whatever your protocol is to prevent you from taking it out of that ward, everybody has to follow it to a T. And it seems crazy, but it really is like hazmat. And so you kind of have to treat it that way. We, for our parvo ward, and we did this with Panluke and then also with Khaleesi, we have gowns. People can, for parvo, actually change their clothes and their shoes and put on new clothes and shoes that are just for the parvo ward, and then when they're in there, when they're finished, they come out and change clothes back. And that's the safest way to do it, but sometimes that's harder. Keeping the isolation ward really far away from the rest of the wards is a good idea too. So if you have multiple buildings, create your Khaleesi or Panluke ward way far away from the rest of the cats so that that accidental crossover is less likely to happen.
And you want to do, when you make this isolation unit, you want to make sure that you're supplying it and everything that you put in there stays in there for the duration of the time. Pens, staplers, tape, Ziploc baggies, paper towels, they should all have their own set of stuff to use. So it should kind of, it's its own little mini clinic is what it is. So you're adding supplies that are getting used, food and all that, but nothing is coming out except for people. So yeah, it becomes its own little mash unit. Supply it with what you need. If it can't be bleached when you're done, throw it away.
So the Khaleesi, our whole cattery was eventually exposed, so we ended up keeping that as our transition area. We didn't bring any new cats in there. So if there was a new cat with no disease, which we assumed they didn't have disease, of course they all got checked, they would go to different catteries and not ever enter our quasi-cattery while it was closed. And then we had our actual treatment ward separate too. So that helped us to segment the disease and segment our population because we adopted 3,000 cats that year, and if everybody went through that, it would have been a huge nightmare. It still was a huge nightmare, but we were talking about a couple hundred as opposed to 3,000.
Yeah, I mean, this was no, I'm not gonna lie, this was no easy task. I mean, closing our cattery was not a great option, but it was what we had to do. So it was by no means ideal, but you have to do it. If you have to do it, you just have to do it. You can't take shortcuts on it.
Yeah, and we ended up doing adoption events still at other, like PetSmarts and Petco's. We still had outlets for other cats to get adopted. So even though the main adoption cattery was closed down, we even did adoption events in one of our other buildings at our facility. So fosters could bring their cats in and get them adopted, and we just made sure that there was somebody who would be the militant person to not let them just go borrow something from the cattery and bring it over to the adoption event. So treatment's pretty easy, actually. It's just baseline antibiotics, pain medicine if needed, sucralfate to coat the ulcers in their mouth and esophagus. Sometimes they had really high fevers, and we'd have to control that, and of course, good nutrition. The quarantine period, the literature is all over the map. It says months to even a year. So if you have a cat that's had the disease, you know, there was no good evidence that it would take that long, but that was just what some researchers were reporting. So we ended up choosing 2 weeks as our period of watching them to make sure that they were really over it. They didn't relapse in any way. And then we started moving them out to different facilities. We had a plan to do that. So what we would do is pull one that was over it, put it into a cattery, not in the same cage, but into like one of our PetSmarts, into a habitat, and not do anything else. No more cats in for another 5 days, and just watch and check everybody else in the cattery daily. If nobody broke with disease, then maybe pull in 1 or 2 more, wait 5 days, and we just did a stair step, and eventually we found that we were fine. And once they were over the 2 weeks, they stayed over it and they didn't spread it to other cats. We also had disclaimers and waivers for the public. So if it really lasted a year, we needed to tell people that if you have cats at home, it's possible they could get this. We don't think they will, but it's possible. So we really tried hard to adopt these to single pet homes and also make sure people had a handout with all the information on it so they could make a good educated decision if they did have another cat at home. And then of course we just redirected people to other cats that had never had the disease too. Reintroducing, we also made a list of everything in the ward. We made this list before we started cleaning so that we didn't forget anything. And so we just brain dumped, everybody who worked in there brain dumped everything they could think of that's in there, and then we just marked off, okay, clean, 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 clean. And we threw away a lot of stuff, actually. It caused a lot of high emotion with us. We weren't used to anything like this, and so it was important we had meetings where we came together and tried to figure out a strategy. The good thing about Khaleesi is that 100% of our cats survived. The death rate is very, very minimal. It's just a morbidity problem of illness. And everybody was really proud that we didn't have to kill a single cat. And so I think that also speaks volumes to the motivation you can inspire in your team if you're trying to find a solution that's going to save more lives.
And really the hardest thing is just planning, making a schedule, making sure that there's a staff schedule or a volunteer schedule so everybody knows the cats are getting fed in the morning, they're getting fed in the evening, they're being treated in the morning and evening, making sure that there's no loopholes in that way and something's getting missed. So a lot of planning, a lot of scheduling. Other than that, you know, it's not the hardest thing in the world to treat.
Mm-mm. The pan-Luc, I won't spend a ton of time on this because if you really have pan-Luc, the parvo presentation can apply to cats. It's parvovirus, this exact same thing. So you can do the exact same thing that we do for dogs that you can do it for cats too. But there are some things that are worth mentioning. One is it's very hard to identify. Puppies, it's easy. I mean, you know, everybody knows what parvo looks like in puppies. In kittens, we were slow on the uptake of what it was when we started seeing it because some would eat, some had diarrhea, some were vomiting, but they didn't all have the same symptoms. And so we started to clue in that if they're not eating and they're vomiting or they've got diarrhea and they're vomiting, then that would push us to a test to try to figure out if that's pan-Luke. But you also can have a lot of false positives if they just got vaccinated. This is a disease that will come up with a false positive test. You can get false negatives if it's early in the disease, just like puppy parvo. So you have to isolate those cats somewhere. If you think it's pan-Luke, isolate them anyway, but maybe not in the ward with the definite positives, if that makes sense. And I'll run through this too. This is just, when you have an outbreak of disease, or you have a group of animals that have broken with something bad, what you want mentally, the exercise you want to go through is to retrace their steps and try to figure out who else they could have exposed and where else in your facility is going to be problematic for more cats. So with cats coming in with kittens coming in with pan-Luke, they could have picked it up outside. Of course, we can't control that, but the number of kittens that had pan-Luke was too high for it to be outside source, unless they all came from the same colony, which they didn't. So we know they didn't get it. We know the outbreak wasn't because of something that happened outside. It's most likely something that happened in our shelter. And again, that's part of sheltering. It's part of having lots of animals in one place, especially animals that are too young to be vaccinated or build up good immunity. The second place they go is intake. And this happened in our bottle baby ward, and you know, this is ideal. They put on gloves and a gown to do a quick feeding at intake. That never happens. You know, people generally, if they're going to do a quick feeding, it's a quick feeding, and then you put them back. And the problem is that if you have pan-Luke on any of those items and many more, you don't know. You're not going to. If you're the one wearing it, you don't know that that's there, and you won't know for a day or two. And tracing it back to you is almost impossible. So your intake procedures and climate needs to be very, very clean, and just assume that there's disease in every litter of animals. It's really hard to do in practice. It's really hard to remember. But if you just assume it, you'll never have these massive outbreaks if you're doing really good sanitation protocols to begin with. The third place was the med clinic, so they go through intake, and then the shelter, city shelter would call us and say, we've got bottle baby kittens, come get them. So we'd come get them, bring them to our medical clinic, and then our medical clinic has all the same things that we could have exposed. We could have been the exposer. And nobody cleans the cabinet knobs in between animals. Nobody sprays their hair with trifectant, you know, in between animals. Nobody does any of that. And so that's, again, the reason to hold them away from you and to not try to cuddle so much. The next place was the nursery, and of course this is probably the most likely place because they're spending so much time in there. There's tons of kittens coming in and out. They have to be held a lot by a lot of different people, and the medicine bottles that they're holding, you know, those typically don't get cleaned. All the things, the cage doors, how many times are they actually getting scrubbed down? You know, it's all these little things that you forget about that are probably the culprit. And during our pan-Luke outbreak, we actually kept taking kittens because the vast majority of them survived. And even though we knew there was an issue and we were trying to isolate it and move it away, we felt like if they had a even 60% survival rate, that's better than what they had if we said no, which was 0. So the good thing about that is that we were forced to figure it out. We were forced to solve this problem because it wasn't an option just to say, okay, we're done. We're not going to take any more kittens this year. Foster homes, really not very likely if you have an outbreak. It's possible, but it's not likely. The test, if you have a cat that's symptomatic and meaning vomiting, a kitten, and it's a positive test, I would trust it. If you have a vomiting kitten that's not responding to medications like injectable antibiotics, which would calm the GI flora issues, and it's still negative, I'd probably assume that was positive. So it is tricky. Again, if you have a vomiting, I think in a kitten is probably your biggest indicator that pan-Luke is there, and try to isolate those kittens as best you can.
It's also one of those things, what are you going to do if it's negative? Probably do the same treatment anyways. So the only difference is knowing if it's contagious or not, but it's worth not testing to possibly get a false positive, false negative, to just treat it like it is, you know, and treat the contagion aspect of it like it is too. Treat it like it's contagious, and we'll just maybe not know, but that's okay.
Yeah, as long as you can isolate definitely. And I can send this to you. I know we don't have much time left, but let me see where we are. The treatment we used for Khaleesi is general antibiotics, bigger guns than what we use for, for Panleuk. We use the same type of drugs as we use for Parvo. They're bigger guns, they're injectable because the GI system can't absorb anything. And Cerenia was the only drug that worked for vomiting in kittens. It's really expensive, and we tried really hard not to use it, but nothing else worked for vomiting. And then force feeding, they need to be force fed a lot because kittens have no fat reserves, so they can't afford to go a day or two with no eating while they get past it. Like puppies can. Puppies can go 3 or 5 days without eating. Kittens can't, they can't survive. So we've got to stop the vomiting and get the food down them. Preventing is super easy. Vaccinations, you can still get it just like Parvo. It's just not as prevalent in kittens that have any vaccines. It's not as prevalent as Parvo is in the dog world. One thing we did, and I think this, so we created, because of the Panleuk problem, we were taking in 1,100 to 1,800 kittens a season, and we had sort of a general room. For those of you that were there earlier today, I mentioned the Wildlife Center, and they just set up cages and went from cage to cage to cage. And that's how we did it. We just copied them. But when we got the Panleuk outbreak, we realized that that's way too many animals to be exposed to. If there's a small group that breaks with it, everybody's exposed, and that's a nightmare to deal with. So an all in and all out is basically an isolation unit. We created 3 isolation units, and they're treated just like our Parvo ward, almost, in the sense that you don't want people running in and out of there. The supplies are not shared. The staff goes in one room and stays in that room instead of going to the next room and then to the next room. And the purpose of that is if somebody does break with the disease, it's very contained, and you've only exposed a certain number of kittens instead of your entire kitten program. And it's worked like a charm. We lost 40% of our kittens in 2012. In the last 2 years, we've been at 10% mortality, which is better than nature. So this has worked amazingly well. And so I would recommend that if you have very vulnerable populations and you have a whole bunch of them, spread them out and try to create ways for them not to overlap at all, so that because it's inevitable. Kittens and puppies are going to have diseases and they're going to spread them. And then we also developed an alert system so that even if we didn't have a positive test or we didn't have enough criteria to test, if a kitten was losing weight, then the manager could mark them in some way. And if there were too many that had marks, then we knew something was going wrong. Either we didn't have enough feeders or they were sick. But it brings your attention to that issue faster than if you're just waiting. Kittens can die pretty quickly before you realize you've got a problem. So that helped quite a bit. And let's see, that's a picture of 2 of the separate rooms. They're just offices that we moved in cages and turned them into 3 separate wards. And so traditional way is just kill all the sick cats so that they're no longer capable of spreading the disease, which is much easier. But when we're trying to go about no-kill, it's kind of like Ebola. You just have to deal with it. I mean, you're not going to kill people because they got exposed to Ebola. We kind of have the same thought, is we'll just try to isolate. We'll try to deal with the disease as best we can to save the individual animal and also not spread it all over the world. I created a couple of questions at the end. And I know we only have a couple of minutes, but so these are some sort of rhetorical questions, but they're things I hear all the time because I think it's just human nature. That first one, is it okay to grab something out of the isolation room if you walk through a foot bath? No. Isolation, if you have isolation, you need to pretend like it's on a separate continent. It's not possible to go borrow something. It's not possible to just pop in and check on an animal. It's not possible to do anything in there without going through a whole bunch of rigmarole to get in there, if that makes sense, because the easier it is, the more likely you are to spread disease. Feeding, so one problem, if you don't have enough feeders, you can go from in between populations, but always treat or deal with your healthy animals first, and then go to your sick animals, and then go home. Don't ever go sick to healthy and back and forth, because that's just going to spread problems. We've had instances where fosters were allowed to come in and pick their own kittens. It's like, no, isolation means isolation. And I wish we had a better word for it that would help it stick in people's brains that it's really serious to keep people out. All right, I guess that's it. If you have questions, feel free to ask them. I'm so sorry we had to run through that so fast.